All right, party people, we are back at it with part 2 in this cardio Pharm series. Let's get it. So, hopping into dobutamine. Dobutamine is a beta 1 agonist. It increases the heart rate and contractility. You have to know that dobutamine can be used as a pharmacologic stress test agent in patients who can't exercise. For example, those with severe osteoarthritis or large abdominal aortic aneurysms. If you want to assess for MI perioperative risk, you have to be able to do this without an actual exercise test. Instead, you'll use a pharmacologic stress test such as dobutamine, which will increase the heart rate, and you can evaluate cardiac function with an echo. And this is done to assess for ejection fraction, etc. For amiodarone, amiodarone is a potassium channel blocker. Don't worry too much about the classifications like class 1, class 2, class 3. Just focus on what you need to know for this exam. So, for example, amiodarone is associated with torsades de pointe or torsades de pointes. This is a dangerous sinusodal rhythm defect that can degenerate into ventricular fibrillation. It can also cause graying skin discoloration. So amiodarone can cause thyroiditis, which may present as hypo or hyperthyroidism. In thyroiditis, such as de Quervain, or drug induced by amiodarone or lithium, you may see decreased radioactive iodine uptake in hyperthyroid state due to hormone release, not overproduction. Basically, the inflammation causes the release of preformed thyroid hormone that basically leaks out from the thyroid. It's not an increase in production. Amiodarone is used for ventricular tachycardia in stable patients. If the patient is unstable, such as low blood pressure or unconscious, you use electrocardioversion, which is the synchronized shock. Moving on to quinidine. This is a class 1A sodium channel blocker. You also have a high risk of TDP with this. That's torsades de pointe. And you may get a vignette where a patient is on an antiarrhythmic and then suddenly presents with headache and ear ringing. This is quinidine. So you just have to know this fun fact for quinidine. Moving on to digoxin. Digoxin has two key effects. Number one, it increases contractility. Number two, it slows your heart rate. For those of you wanting to know the mechanism, it blocks the sodium-potassium ATPase pump. This increases intracellular sodium. This inhibits the sodium-calcium exchanger, which in turn allows calcium to build up inside the cell. And finally, this results in an increase in cardiac contractility. Please note that it also has parasympathomimetic effects, which also slow the heart rate. So you have an increase in contractility, but a decrease in chronotropy. Now, in terms of toxicity risks, you have to be aware that hypokalemia increases digoxin toxicity because potassium competes for the same binding site on the ATPase pump. Rarely, you might also see that hyperkalemia can be caused because of the buildup of potassium in the blood due to the blocking of said pump. Classic digoxin toxicity symptoms are visual disturbances, where you'll have yellow, wavy vision. You have to be aware that digoxin does not decrease mortality in heart failure. This is simply a symptom-controlling drug. Mortality benefit comes from ACE inhibitors, ARBs, beta blockers, spironolactone, and hydralazine nitrate combos. You will be tested on them. You have to know this list. Moving on to furosemide, aka Lasix. So this is your classic loop diuretic. It's very efficacious for fluid unloading. It works by blocking the sodium-potassium 2-chloride cotransporter in the thick ascending limb of the loop of Henle. This is used when you have significant fluid overload. Think pulmonary or peripheral edema. In heart failure, you use an ACE inhibitor or ARB as first line to improve ejection fraction. But if all of a sudden the question also gives you dyspnea, crackles, fluid overload, furosemide is often your correct answer. Now, in terms of side effects, you have to be thinking hypokalemia due to the direct potassium loss and increased aldosterone-driven potassium secretion. You can also have contraction alkalosis. This is from volume loss and the renin-angiotensin-aldosterone system. You'll have ototoxicity, tinnitus, and vertigo, as well as increased urinary calcium. This may precipitate calcium stones forming. If a patient's already using furosemide and needs another diuretic, almost always you have to give the additional potassium-sparing diuretic like amiloride, triamterene, spironolactone, eplerenone. Do not pick a thiazide because they also lower potassium. Now, in terms of comparing and contrasting loop via thiazides on calcium, loop diuretics increase urinary calcium, which can worsen stones. Thiazides decrease urinary calcium, can be used to prevent said stones. Now, moving on to thiazide diuretics such as hydrochlorothiazide. Their mechanism of action, they block the sodium chloride symporter. This is found in the early distal convoluted tubule. Common uses of thiazides are hypertensive patients without comorbidities. So if they don't have diabetes, coronary artery disease, heart failure, you can use them. But if they do, you will be using an ACE inhibitor or ARB instead. In terms of side effects, you have to memorize hypergluc. The G in hypergluc stands for hyperglycemia. The L stands for hyperlipidemia. The U stands for hyperuricemia. The The C stands for hypercalcemia. Another notable side effect is gout. You can also have milky nipple discharge known as galactorrhea. It is rare, it can sometimes be tested. You have to be cautious with spironolactone in diabetics because it can cause hyperkalemia and kidney issues. The typical drug hierarchy in heart failure is ACE inhibitor, followed by beta blocker, followed by spironolactone with caution. Sometimes you'll be presented with a patient who was put on thiazide before spironolactone, but stick with the order that you are being shown here because otherwise you're going to get the questions wrong. All right, that's it for this one. I'll be coming back with a part 3. Go crush it.